Now that we have learned about testing, we will discuss syphilis staging. In this lesson, you will learn how to stage cases of syphilis using our surveillance case definition. You will be able to identify symptoms of primary and secondary syphilis. You will be able to use staging to calculate interview periods for primary and secondary syphilis. You will also learn how to identify signs of clinical manifestations. Finally, you will determine whether a case of syphilis meets the case definition. This slide represents a timeline of what we see during a syphilis infection. In the first year of infection, someone exposed to syphilis will fluctuate between symptomatic and asymptomatic stages. As previously discussed, these symptomatic stages are called primary and secondary syphilis. These stages are important because they are the only points in which someone can pass syphilis to their sex partners. The primary stage is characterized by the appearance of a painless lesion. This lesion is required to be present at the time of testing to consider stage as primary for surveillance purposes. There may also be localized swelling of lymph nodes. Symptoms can easily go unrecognized, especially in receptive partners, because the lesion will appear at the site of infection, which would usually be the vaginal canal, rectum, and/or oral cavity in receptive partners. A primary syphilis case would be assigned the disease code of 710. Here are some examples of primary lesions. Again, the lesion will appear at the site of infection. Typical lesions are found on the genitals, in the rectal canal, and in the oral cavity. Here we have an example of a digital lesion, or a lesion on the finger. Remember that syphilis is transmitted by coming into skin-to-skin contact with either a syphilitic lesion or coming into contact with mucus patches in secondary syphilis. This is one of the many reasons why providers wear gloves when performing an exam. Here are some more examples of non-genital lesions. Note the localized swelling. We would still consider these persons to be in the early stage. Onset of primary syphilis lesions occur between 10 and 90 days after exposure. 3 weeks is the average. The period before the onset of symptoms is also called the incubation period. When the lesion appears, the primary stage begins, and it can last up to 5 weeks with an average duration of 3 weeks. When investigating a case of primary syphilis, you'll want to ask about partners in the last 4.5 months, prior to the date the lesion was observed up until the day of treatment. With an interview, you are trying to identify both the person who exposed your case to syphilis, and you are trying to identify persons your case may have been exposed to. For this reason, we need to include the maximum incubation period, which is 13 weeks, and we need to include the maximum duration of primary syphilis symptoms. Although a lesion was observed, we don't know when the lesion first appeared, so we can use the maximum duration of symptoms, or 5 weeks, in our calculation of the interview period. When we add these numbers together, we get 4.5 months before date of lesion. A tip for you when you do your partner elicitation. You'll want to frame it in the context of calendar year. So if the lesion appeared around May 30th, you know that 4.5 months prior to that date was the middle of January. Instead of saying, tell me about the partners you've had in the last 4.5 months, you should ask your case, tell me about the partners you've had since the middle of January. Anchoring around the holidays and birthdays and memorable moments can also help patients conceptualize the time frame you are talking about. Now let's discuss secondary syphilis. Symptoms of secondary syphilis can include any of the following. A generalized or localized skin rash is a common manifestation of secondary syphilis and appears in 75 to 90% of cases, though it can vary in coloration, texture, and location on the body. If you see a rash on the hands and/or feet, this is referred to as a palmar plantar rash, and it appears in 60% of secondary cases. A palmar plantar rash is very unique to syphilis. Other causes of palmar plantar rash include contact dermatitis and hand-foot-mouth disease. Patients may have nonspecific symptoms, including a sore throat, low-grade fever, malaise, and generalized swollen lymph nodes. Remember, if it is localized around a primary lesion and there are no other signs of secondary, we would consider it to be a primary case. If it is more diffuse or further away from the primary lesion, or if there are other signs of secondary syphilis, then we would count it as a secondary case. Other manifestations of secondary syphilis that are less common include mucus patches, which are thickened white to gray lesions that appear in the mucous membranes, mouth, vaginal canal, and rectum. Celata, which are moist, wart-like formations that resemble cauliflower. Both the celata and mucus patches are incredibly infectious. 10 to 15% of cases will have patchy hair loss or alopecia. You will want to become familiar with the terms in the slide because you will have to review medical charts to look for symptoms of secondary syphilis. A secondary case would be assigned the disease code of 720. Here are some examples of celata. They can have a pinkish white wart-like appearance, typically appearing in the skin folds and genitals. Here are some examples of generalized or localized skin rash in varying coloration, texture, and locations on the body. Here are some more rashes in that very classic palmar plantar location. Again, any provider who sees this symptom should think syphilis, especially considering rates in Arizona have been increasing for 5 years statewide. Here are some examples of scrotal rashes related to secondary syphilis. And here are some examples of mucus patches lesions in the oral cavity. These are very infectious lesions. Now here's an example of alopecia, or patchy hair loss. This photo shows hair loss to the scalp, but alopecia can occur in other locations, such as a person's beard. Now let's discuss the secondary syphilis, the timing of secondary syphilis as it relates to your partner elicitation interviews. Secondary syphilis typically occurs 3 to 6 weeks after the primary lesion, but it is possible to have the primary symptoms overlap with the secondary symptoms. So we are now somewhere between 1 and 6.5 months after exposure. Though on average, secondary syphilis will start 2.5 months after exposure. The duration of symptoms are between 2 to 6 weeks, with an average duration of 4 weeks. The interview period for secondary syphilis is about 8 months. As with primary syphilis, we use the maximum incubation period, which is 90 days after exposure, plus the maximum duration of primary symptoms, which is 5 weeks, plus the maximum time between primary and secondary syphilis, which is 6 weeks. Also, plus the maximum duration of secondary syphilis, which is 6 weeks. And that's how we get our interview period. This totals to 34 weeks, or a little over 8 months. So you will want to ask about all partners in 8 to 8.5 months prior to the secondary symptoms up until the time of treatment if you're doing a secondary interview. Many of our guidance documents use 8 months as the interview period for secondary. Let's go back to the full timeline. So we've talked about the primary lesion and we've talked about the secondary symptoms. In the first year of infection, the time between these two infectious periods is known as early non-primary, non-secondary syphilis. If you can prove that a person acquired syphilis within the last year, but they are not symptomatic at the time that they are seeking testing, then we would call them an early case. So this includes persons who are in their incubation period, persons who are between primary and early, and persons who just completed their secondary stage. Here are some examples of evidence you could use in your investigation to support your justification for staging someone as an early case. If you have a history of negative syphilis tests in the past year for someone who is asymptomatic, they would be staged as early. If you're ever working a co-infected HIV case, remember persons in HIV care should receive syphilis testing annually, so you may be able to get a history of a negative result from their HIV care provider. As discussed in our titer section, if you have someone who demonstrates reinfection, so a sustained 4-fold increase in titer, following appropriate treatment within the last 12 months, you can call them an early case. If you have history of symptoms in the past 12 months, you may be able to call the case an early case, depending on the type of symptoms reported. If the case is linked to a primary or secondary case, and their exposure periods overlap with the infectious periods of their primary-secondary partners, then you can call them an early case. And if you have someone who reports that their sexual debut occurred in the last 12 months, you can call them an early case. Sexual debut is defined as their first time having any type of intimate contact that could expose them to syphilis, so typically vaginal, oral, and anal sex. An early syphilis case would be assigned the disease code of 730. Persons who do not meet case definition of primary, secondary, or early non-primary, non-secondary will be considered late latent or unknown duration. Evidence to support a late latent or unknown duration diagnosis include no signs or symptoms, history of symptoms more than 12 months prior to the most recent test, no history of a negative test in the last year, a fourfold increase in titer following appropriate treatment more than 12 months prior to the most recent test, and no other evidence to support a primary, secondary, or early non-primary, non-secondary diagnosis. A late latent or unknown duration case would be assigned the disease code of 755. Let's take a moment to talk about incubation and infectious periods and how they impact the transmission timeline. We've already established that incubation period is the time between when you are infected and when the first symptom appears. At this point in the infection, you do not have symptoms, and for syphilis, you cannot pass the infection to others. The infectious period is a period of time in which you are capable of infecting others. Syphilis has a really long incubation and infectious periods relative to other infectious diseases. Many infectious diseases like meningitis, influenza, measles, and hand-foot-mouth disease have incubation periods ranging from a few days to a couple of weeks, and their infectious periods only last a couple of weeks. STIs are different. For chlamydia and gonorrhea, you are considered infectious until you are treated. For syphilis, you go through a potential 3-month-long incubation period, then you pass through 2 infectious periods that can last for over a month. And 25% of untreated syphilis cases will have a third infectious period if they have a secondary relapse. This, combined with the subtle nature of syphilis symptoms, is what can cause syphilis outbreaks to drag on for years. So when you are looking at an epi curve of STIs, you really have to step back and look at the disease trends over several years. Here's an example of a resource that is available in our investigator toolkit. This flowchart summarizes the staging we have discussed in this module. The first thing you want to ask for is if there are signs and symptoms of primary or secondary. If there are no signs and symptoms present at the exam, then you would want to run through the checklist of possible indicators of early infection. If there's nothing to support an early staging, then you would classify it as late. Now that you understand the stages of syphilis, we can start talking about the 4 manifestations of syphilis. When left untreated, as you know, syphilis can invade the central nervous system and cause problems with your hearing, which is called otic syphilis, your vision, which is called ocular syphilis, and your brain, which is called neurosyphilis. The first 3 manifestations can appear at any stage of infection. The 4th category includes late clinical manifestations. Unlike neuro-ocular or otic, late clinical manifestations usually develop 10 to 30 years after infection. You may see the range 15 to 30 referenced in the surveillance guide. For surveillance, if any of these 4 manifestations are suspected, you will have to indicate whether the manifestations are probable, likely, or verified according to the most recent case definition. Refer to the classification chart available in our investigator toolkit to help you make these determinations. For now, we'll do a high-level overview. This slide shows the clinical descriptions for each of the 4 manifestations. Be on the lookout for these terms in your medical chart review. Neurological manifestations impact your brain, causing things like meningitis, which is swelling of the lining of the meninges. It can also cause memory problems like dementia and so on. Ocular syphilis can impact your vision, leading to blindness, and otic can cause hearing loss, tinnitus, and even vertigo. Late clinical can cause lesions throughout your body, damaging multiple systems, including your cardiovascular system. This is an infection of a skin lesion called guma that may appear during a late clinical manifestation of syphilis. Clinical classifications would call this tertiary syphilis, but in surveillance, we call this a late clinical manifestation. Late clinical manifestations can affect multiple organ systems, including the brain, nerves, eyes, heart, blood vessels, liver, bones, and joints. Symptoms of tertiary syphilis vary depending on the organ system affected. Again, these manifestations appear 10 to 30 years after the infection and are rare. To meet the possible definition of neuroocular otic syphilis, there needs to be a reactive treponemal or non-treponemal test. They need to match the clinical signs and symptoms as described on this slide, and there has to be no other known cause for the symptoms. Note that there is no possible classification for late clinical manifestations. To meet the likely definition for neuroocular otic syphilis, there must be all of the signs consistent with possible definition, which is a reactive treponemal or non-treponemal test, clinical signs and symptoms as listed on the side, and no other cause for symptoms, plus additional signs. For neurosyphilis, the additional sign would be an elevated CSF protein or white blood cell count. Again, these manifestations appear 10 to 30 years after infection and are rare. For ocular syphilis, the additional sign would be any findings in an ophthalmologist exam that are consistent with ocular syphilis. For otic syphilis, the additional sign would be any findings in an exam that are consistent with otic syphilis. For late manifestations, this would be any of the listed signs and symptoms with no other cause or the presence of signs or symptoms consistent with late neurosyphilis that meet likely criteria for neurosyphilis. For verified, you need to meet the possible definition, and for neuro, you need a reactive CSF VDL. For ocular, you need a reactive dark field or PCR vitreous fluid. For otic, you need to have a reactive dark field or PCR of the inner ear fluid. And for late clinical, you need to have demonstration of syphilis late lesions by special stains, PCR, or equivalent direct molecular methods, or a late neurosyphilis case that meets the verified criteria as outlined in this slide. We know that this is a lot of information, and you have been provided a handout on neuroocular and otic and late manifestations within your investigator toolkit. Now let's go back to our timeline. Not only can neuroocular and otic manifestations appear at any stage, but pregnant persons can pass syphilis onto their developing fetus at any stage. When we are talking about primary and secondary syphilis transmission, we are very intentional about saying that transmission to sex partners can only occur in the primary and secondary stages. With perinatal transmission, it can happen at any stage, but the most severe health outcomes occur if a mother is infected immediately before or during pregnancy. Now let's do another scenario. You find out that a person who was recently treated for syphilis has given birth in the past year. Should you follow up on the baby to determine if they have been tested or treated? It depends. The main thing to ask yourself is whether or not the baby could have been exposed to syphilis while she was pregnant. If the woman was diagnosed as primary in December of this year, but she gave birth in July of this year, she would not have been infected with syphilis at the time that she gave birth, and there is no need to follow up on the baby. However, if she was diagnosed with latent syphilis and she gave birth within the last year, looking at her prenatal records may indicate that she has a history of negative syphilis if she was tested at delivery, which can help you classify the mom as an early case. Similarly, if she was diagnosed with early syphilis and she gave birth a month prior, it's possible the baby was exposed to syphilis, even if the mom tested negative at delivery. So we will want to make sure that the baby was tested and treated. Most cases of syphilis wind up meeting the probable classification. In order to meet the confirmatory definition, you would have to demonstrate the presence of syphilis using dark field microscopy, PCR, other equivalent direct molecular methods. Not only is this equipment for dark field testing incredibly rare, but you are only able to directly observe the spirochetes if someone is in one of the symptomatic stages like primary or secondary. The Maricopa lab does have a dark field microscope, so you may have an occasional case meet the confirmed classification. Most of the cases you work will ultimately be classified as a probable case. To meet the definition for probable, you need to have a reactive non-TREP, which includes VDRL, RPR, or equivalent methods, and you need to have a reactive TREP test, which includes TPPA, EIA, CIA, or other equivalent test. There is one exception to this rule. A primary case only needs to test positive on one test, even if they have discordant test results. As long as they have a primary lesion and one test is positive, they would meet the case definition for primary. You can learn more by checking out the full case definition for syphilis on the CDC website. Now let's put together everything we have learned so far about disease codes, case classification, and staging. 700 is an initial disease code used to describe a case that has either been ruled out or that is still under investigation. For example, if we receive a reactive RPR and a non-reactive TPPA on a case, we would initiate a syphilis field record and assign the disease code 700 while it is being investigated. If we determine this person was a biological false positive, we would close the record as 700 and indicate no for the question of morbidity. This tells us our analysis programs to ignore these records when they are running case counts, since the investigator has indicated through the morbidity value of no, they do not meet the case definition. 710 is the code for primary syphilis. To meet the definition of primary syphilis, you have to have a primary lesion at the time of testing and reactive on at least one of the TREP or non-TREP. Going back to the example of someone with a reactive RPR and non-reactive TPPA, this case might start as a 700, but if the investigator received a communicable disease report on med records indicating the patient had a primary lesion at the time of testing, the investigator would update the disease code to 710, investigate the case, and ultimately close the field record answering yes to the question of morbidity. The morbidity of yes tells our analysis program to include this case in our counts, and stage of 710 tells us our program to mark it as primary case, since the investigator has determined that it meets the case definition for primary syphilis. 720 is a disease code for secondary syphilis. Someone who has at least one symptom of secondary at the time of initial testing and is reactive on both the TREP and non-TREP would meet the case definition for secondary. 730 is a disease code for early syphilis. Someone who has evidence of infection with the last 12 months, history of primary, secondary symptoms in the past 12 months, and who is reactive on the TREP and non-TREP test would meet the case definition for early non-primary or non-secondary. 755 is the disease code for late latent syphilis of unknown duration. Anyone who has a reactive TREP or non-TREP but does not meet the symptomatic criteria for primary or secondary and does not have evidence of an early infection would meet the case definition of late latent syphilis. You may occasionally see the codes like 740 or 745 for older records. 740 is used to indicate unknown duration, and 745 is a historical disease code that was used for late latent. 790 is a disease code for congenital syphilis. We'll cover the congenital case definition in a different course. These disease codes are used nationally, so if you're talking with an investigator from another state, they should know what you mean if you are investigating a 790. In this lesson, you learned about each of the stages of syphilis. When people are capable of passing infections and how to use staging to determine when exposures could have occurred. You also learned how to identify the symptoms of primary and secondary syphilis and how to classify neuro, ocular, otic, and late clinical manifestations. Finally, you learned how to apply the case definition to each stage of syphilis.